Yes. Here is a 18-year-old female with a fever, headache, and vomiting of 1 day duration, and patient was noted to have rash on the legs. Blood pressure at the time of admission was 90 by 60 millimeters of mercury. A CSF study was undertaken. Pressure shows 300 millimeters, normal pressure being 60 to 150. The fluid was turbid, protein is 120 milligram, glucose was 0, corresponding blood glucose was 78 milligram percentage, cells 120 per ml, pleocytosis, and neutrophils were 100%. With this background story, what is your diagnosis? The diagnosis has to be bacterial meningitis. Reasons being, duration is very short, 1 day, and the patient's CSF shows pleocytosis, indicating infection. Cells are all neutrophils, and glucose is very much reduced to 0. So, what can be the diagnosis? With the rash on the legs, we have to think about meningococcal meningitis as a possibility. And why hypotension? Hypotension may be cause of bleeding into the adrenalitis, adrenal crisis, Waterhouse-Friderichsen syndrome. What is the next investigation of choice? Whenever there is pyogenic meningitis, next investigation of choice is a study of the CSF with gram staining and taking a corresponding blood culture and sensitivity. Now, looking at the spectrum of bacterial meningitis, in this case, it can be only a meningococcal meningitis. Other common causes of bacterial meningitis are pneumococcal meningitis, and if the gram stain is showing gram-positive rods, then you have to think about Listeria meningitis. So pneumococcus is the commonest, meningococcus comes next, and in immunocompromised people, Listeria monocytogenes. In a healthcare associated background, you have to think about staphylococcal infection as well. Now, what is turbidity showing? Turbidity can be because of infective causes or non-infective causes. And whenever the RBC count goes up very high or WBC count goes up very high, you can have turbidity. More than 200 WBCs or 400 RBCs can make it turbid. What is the emergency treatment? Emergency treatment is going hand in hand, one, with the treatment of adrenal crisis with rapidly acting steroid hydrocortisone, IV fluids, normal saline, and then of course we have to give appropriate antibiotic. Definitive treatment for this depends upon the organism you have got. Meningococcus, ideal drug will be third generation cephalosporins, ceftriaxone. With Listeria, think about ampicillin, H. influenza, third generation cephalosporin. So, if it's a pneumococcal meningitis, of course, third generation cephalosporins or penicillins may be effective if there is no resistant strain. And it is routine to give steroids for all the patients with pyogenic meningitis, bacterial meningitis to avoid further complications. 27-year-old male with a fever, headache and vomiting of 5 days duration. Also the patient had myalgia and arthralgia. With a diagnosis of meningitis, a CSF study was done. It shows pressure of 300, the fluid was turbid, protein was 50, glucose was 80, corresponding blood glucose 100, with 1000 cells per ml, and all the cells were lymphocytes, 100%. What is your diagnosis? The background story, fever, headache, vomiting, indicates meningitis. Presence of myalgia and arthralgia points to viral meningitis, and supported by presence of lymphocytosis in the CSF, 100% lymphocytes, and also note, in spite of elevated protein, elevated pressure, the glucose is maintained as normal. So this is a clue to the diagnosis. First one, history of myalgia, arthralgia, followed by normally preserved CSF glucose, lymphocytosis, and elevated protein. So what is the next investigation of choice? We have to go for PCR and find out what is the possible organism producing this viral meningitis. We can have arbovirus infection, like West Nile fever and so on. And the differential diagnosis will be including the early stage of tuberculosis meningitis, day 1, where also you may find CSF changes of this type. 25-year-old female presents with 3 months of fever, headache and vomiting and features of meningeal irritation. A provisional diagnosis of meningitis was made and CSF was studied. Pressure is 200, fluid was turbid, protein is 1 gram, glucose is 20, corresponding blood glucose is only 120, cells 1000 per ml, and all the cells were lymphocytes. What is your diagnosis? As you can see from the history, duration of the illness is 3 months, indicates a chronic disease process. So we have to think about a chronic meningitis in this case, the commonest being tuberculous meningitis. What is the next step you will do? Next step is keep the fluid overnight and look for cobweb and take a smear and do AFP staining. You also have to do CSF for AFP staining. You also have to take the fluid for ADA, and ADA may be high in cases of TB meningitis. CBNAT can also be done for TB meningitis, but the point to be noted is adenosine deaminase ADA may be elevated in tuberculosis, brucella, and other chronic infections. So, any patient with meningitis, we have to consider the clinical pattern, the chronicity of the disease, and interpret accordingly. Differential diagnosis will be all types of chronic meningitis. And what's the basic pathology? Basic pathology is it produces exudates in the base of the meninges, producing basal meningitis. These exudates can create lot of complications. And what is the possible pathogenesis of TB meningitis? TB can be characterized by TB basilemia following a primary infection, and it can leave behind scattered foci in the brain or meninges or adjacent cortical bone. There can also be tuberculoma. When they rupture into the subarachnoid space, you get intense inflammatory changes producing meningitis. That is the pathogenesis of meningitis as such. And what are the complications and the pathogenesis? Complications occur because of the exudate in the base of the brain, which will be entangling and pulling the cranial nerves, producing inflammation of the vessels, producing arthritis, or producing phlebitis, thereby leading on to edema of the brain. It can also create problems by coating the arachnoid villi, impairing the CSF absorption, and can occlude the foramens Luschka and Magenti, producing hydrocephalus. So this disease can produce cranial palsies, hydrocephalus communicating, non-communicating. It can produce infarcts, it can produce cerebral edema, and it can also, by different mechanisms, can create different types of presentation to the patient. Patient may become blind, patient may become deaf, or can have different types of cranial pulses. Treatment is just like for any other CNS tuberculosis. You have to treat the patient with ATT and steroid cover. This is a 20-year-old female with a fever, headache, and vomiting, and the patient was under treatment from another hospital. CSF study shows pressure 180, turbid fluid, protein 60, glucose 50, GRB is 180, cells 100, 50% lymphocytes, and 50% neutrophils. As you can see, this patient is coming from another hospital, and apparently she has received antibiotics from there. So your diagnosis is a partially treated pyogenic meningitis, the CS of glucose is still low. So we have to find out the organism, the possible organism, go for a blood culture, PCR, and continue the antibiotics. A known case of HIV positive patient with headache presents hospital and finds that there is no fever, there is no neck stiffness, only history of the headache. A CSF study shows pressure of 230, turbid fluid, proteins of 100, glucose 60, and GRB is 150, cells being 20, all mononuclear cells. What is the possible diagnosis? This is a classical presentation of cryptococcal meningitis where signs of malnutrition may not be seen, and a high index of suspicion gives the diagnosis. Treatment is continuous treatment of with amphotericin B and frequent lumbar puncture draining the fluid, decreasing the intracranial pressure. A 50-year-old gentleman comes with known case of disseminated carcinoma, presents with headache, and CSF study shows pressure of 300, turbid fluid, protein 150, glucose 50, and GRB is 210, and cells of 100, 50% mononuclear cells, 50% neutrophils. This is the story of a cancer patient and the possible diagnosis carcinomatous meningitis. We have a 29-year-old female with paraparesis following viral fever, and this CSF study shows pressure is normal, colorless fluid, protein is very high at 900, glucose is normal, and there are no cells. This is the classical presentation of Guillain-Barré syndrome, infective polyneuritis, acute presentation. If the duration of the illness is less than 4 weeks, then you call it as Guillain-Barré syndrome or acute infective polyneuritis, and if it exceeds 4 weeks, we call it as CIDP. The treatment is plasmapheresis or IV immunoglobulins. Year-old female is presenting with headache and vomiting, and CSF study shows pressure is 200, fluid is endochromic, protein 180, glucose is normal, all cells are connected, and RBCs are seen. And your diagnosis is subarachnoid hemorrhage. Acute subarachnoid hemorrhage produces a red colored fluid. If you do the lumbar puncture and you get red colored fluid, you take 3 separate bottles, and if it is traumatic, it will get cleared at the end by the 3rd bottle. If it is uniformly blood stained in all the 3 bottles, it will be called as subarachnoid hemorrhage. If the patient is coming after 2-3 days after the bleed, then the picture is slightly different. The color of the fluid will be xanthochromia, because xanthochromia is produced when the hemoglobin is converted into oxyhemoglobin, which is pink in color, and subsequently methemoglobin and bilirubin, which gives it a xanthochromia or yellow color of the fluid. So the diagnosis here is acute subarachnoid hemorrhage. A 35-year-old female presents with weakness of the legs. CSF study shows pressure 10, normal pressure being 60 to 150, very low. Xanthochromia is seen, protein is 1 gram, glucose is normal, cells are only 5. What is your diagnosis? Whenever the pressure is low, we have to think possibly there is marked dehydration, hypotension, or there is something that pressure on the spinal cord blocking the flow of the CSF, producing pressure below the block. So this picture is called as Freund syndrome, and commonly Freund syndrome was diagnosed based upon bedside conformity test, which is called as Quickensted's test, which is applying pressure on the jugular vein. You can see the sudden rise of CSO pressure, and in the presence of complete block, this rise in CSO pressure will not be seen in the manometer, and if it's partial block, it will be slowly rising and coming down. But these days, with the advent of availability of imaging techniques, Quickensted's test or lumbar puncture is not done in such scenarios. So this is Freund syndrome.